Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy JENSEN.
Hi, I'm Dr. Roy JENSEN, director of the University of Kansas Cancer Center. With me is Dr. Stephen Soper, a KU cancer researcher and KU School of Engineering Foundation Distinguished Professor, and Dr. Keith August, a clinician at Children's Mercy, specializing in pediatric hematology oncology. Together, Drs. Soper and August are working to improve outcomes for children with acute lymphoblastic leukemia, also called ALL. Welcome to Bench to Bedside, Dr. August and Dr. Soper.
Thank you.
We'll start off with Dr. August. Can you tell us more about ALL?
Well, in terms of children, ALL is actually the most common type of cancer that we see. And so about 1 in 4 children who are diagnosed with cancer have this specific type of leukemia. It is truly one of the success stories of childhood cancer in that this disease that 50 or 60 years ago could not be treated or did not have a good cure rate can now be expected to be cured anywhere between 85 to 90% of kids. And so it's really an astonishing story of clinical research getting to the point where we are today. Unfortunately, since it's the most common type of cancer in kids, we still see a number of children at Children's Mercy Hospital every year that relapse. And so it becomes difficult with a high cure rate to continue to add things to our chemotherapy regimens because it's not a good trade-off increasing the amount of side effects that people have versus trying to cure the last handful of patients. So one of the things that we focus on now is trying to identify as early as possible children that are going to relapse or have a high risk of relapse, and so that we can alter treatment initially in the first few months, trying to prevent them from relapsing eventually. And that's how Dr. Soper and I have got together trying to identify these patients at an early stage.
So Dr. Soper, you're a biomedical engineer, and Dr. August, you're obviously a physician scientist. Could you tell us about how you two got together and how you work together on this problem?
So I came on board about 3 years ago. And during my visit, before I officially came on board, I met Keith through Dr. Scott Weir. We started talking. I had been working at the University of North Carolina at Chapel Hill on a project looking for minimum residual disease and acute myeloid leukemia. And after I met with Keith, I sent him this paper. He had discussed with me his work in ALL, and it was a logical extension of the work that we'd already done at University of North Carolina at Chapel Hill to carry that work on here at Children's Mercy Hospital and KU Cancer Center.
Mm-hmm. So let's hear a little bit about the ongoing collaboration, which involves identifying optimal treatment approaches for children with ALL. So you're using one of Dr. Soper's custom-made so-called labs on a chip. You can potentially avoid having to biopsy the bone marrow, which for people who have not witnessed that or experienced it, that is an extraordinarily painful procedure, particularly for a child.
So it's very interesting. These leukemia cells that are found in many of these patients are circulating in blood, but they're very difficult to find. Very difficult to find. And usually there's common techniques that are used to find and locate those cells, and that's called flow cytometry. The problem is it doesn't have very good sensitivity. So what that means is it can't find these extremely rare cells when patients are starting to relapse. And what we do is we use a chip that looks like this. It's made from a plastic. It's about 2 inches by 2 inches in size. And what it consists of is certain chemical entities called antibodies that are looking for specific leukemia cells that are in the peripheral blood of the circulation of these patients. So we can, Dr. August and his group actually sees these patients. They've been diagnosed, they've been treated, and we are taking blood draws during their treatment to see, first of all, how they're responding to therapy, putting them in high risk versus low risk groups, and then also long range looking for potential signs of relapse on these patients by looking at the number of leukemia cells that are actually in their blood. So we're using what's called a CD19 antigen that's unique to some of these B cells. This is B cell ALL, and Dr. August can tell us more about that. And looking at these cells and figuring out how many are in the blood of these patients, we can pick up even a single cell from these patients from about a 1 ml draw of blood. We capture these cells, and then we use fluorescence to actually look at them and characterize them. So this is simply, all that is done is this antibody is put onto this chip. The blood is allowed to flow through the chip. We capture the cells, and then we characterize them either by looking at their protein content, or we can also do some other things. For example, looking at further at their molecular composition. For example, one of the things that we're doing with Dr. August right now is doing what's called FISH, or fluorescence in situ hybridization, to look for chromosomal aberrations that might have some prognostic perspective.
We already know that response and how fast patients respond to chemotherapy is a very good predictor of who's going to relapse and who isn't going to relapse. The problem now is that we don't have a great way to test for that. We do bone marrows, as you mentioned, not a fun thing to do in children. It's painful, it's uncomfortable, and most of our kids will get anesthesia, which has its own risks. And so when I heard about what Dr. Soper was doing, it was obvious to me that this was a way that we could avoid doing bone marrows and yet still learn about how quickly patients respond. And also this way you can do it all the time. We see patients once a week, they have blood work, or a bone marrow is just one spot in time where we have a chance to look, and we usually don't continue to do those testing for patients. So I think, this is an optimal way to sort of measure patients week by week to see how they're responding, with the goal of, one, eliminating bone marrows, which we don't like to do in kids, and two, figure out who the slow responders are going to be. And those are the patients that we worry about relapse and can look at changing therapy.
So tell me, maybe just a clarifying question. Are you using this test now to categorize patients and decide on therapy, or is this a clinical research study where you're doing this sort of in parallel with what you're normally doing, and then you'll see if it has impact on clinical decision making down the road?
So at the moment, this is a research study, and we are doing it in parallel. We've never used this chip in ALL before, so there's a lot we have to learn to make it work the right way and to make sure that it's measuring what we want it to measure. The goal is eventually that something like this could take the place of what we do now.
I see. So, and is the only disease that this chip works on, is it just childhood ALL?
No, absolutely not. As I alluded to earlier, we initially started using this specific test on acute myeloid leukemia and looking for relapse in those patients. Those are predominantly older patient pool for AML. The other thing that we've used this chip for is multiple myeloma for staging patients. There we can program this chip with a different type of antibody to look for different types of cells. So those are the liquid-based tumors, the AML, the ALL, the multiple myeloma. We can also target the solid tumors as well, and we got a whole slew of tests programmed with a specific antibody looking for specific tumor cells in circulation as well. Bladder cancer, prostate cancer, breast cancer, pancreatic cancer. In fact, actually, we've got a couple studies going on right now with researchers in pancreatic cancer.
So if you're just joining us, we're here with Dr. Steve Soper and Keith August talking about a KU Cancer Center and Children's Mercy collaboration. Remember to share this link with people who may benefit from our discussion. Use the hashtag #BenchToBedside. So an element of your collaboration is revolves around the use of so-called precision medicine. How would you define that?
So I will give you an engineering perspective, and then Dr. August can give you a clinician's perspective. Precision medicine is basically this. looking at the molecular composition of a particular disease in order to match therapy to that disease. And I use that word generically because it's not just the oncology-related diseases, but other diseases too that can use precision medicine to help augment its promise. And precision medicine was launched by President Obama, ex-President Obama, about 3 or 4 years ago. And what really sets it apart, I think, from personalized medicine, this is the engineering perspective, is that all of the wonderful tools that are now available can help provide greater detail in the molecular composition of one's disease in order to make finer tuning in terms of the treatment regimens for those patients. And this is a good example of new technologies that are available now that's giving us a different perspective of how we can monitor those diseases and actually unravel the molecular composition of those diseases to better treat those patients.
Mm-hmm. So, Dr. August, long term, how do you expect liquid biopsies and labs on a chip to help ALL patients?
Well, as I mentioned earlier, one of the focuses now with a cure rate that's fairly high is to identify patients that we think have a higher likelihood of relapsing. And those are the patients that can get more aggressive treatment, whether that's more aggressive chemotherapy, whether that's a bone marrow transplant, whether that's some new immunotherapy or targeted therapy that we have now. But a patient that is not likely to respond like we want to conventional chemotherapy. And so with this test, kind of my hope is that we will do better than what we do now as far as identifying these patients in an easier way. We can test them once a week. We will have to go back and figure out what the precise levels at what time points will identify these high-risk patients, but then take that forward and say, well, these are patients that aren't going to respond to what we do now, and we need to entertain new therapies for those patients. And so instead of treating every ALL patient differently or with a new therapy, we can focus on the 10, 15, 20% that we know are going to be at a higher risk of relapse.
So as we close out this session of Bench to Bedside, what are some of the key takeaways that each of you would suggest for our audience?
Well, when I first heard about what Dr. Soper was doing, I thought ALL was the perfect disease to start with this in pediatrics because we already have a foundation of knowing the kinetics of response, or how fast kids respond, can predict their chances of relapse. And so I felt like if we could prove in ALL that we can do this better than what we have now, it would be a great starting point. But like Dr. Soper said, the applicability of this is really for all cancer, whether it's leukemia or solid tumors, to be able to see how patients respond using an easy liquid biopsy of blood, using that to predict who's going to relapse and changing therapy using that way. It also has the benefit of being an easy test to predict relapse. And so we don't do bone marrows on patients routinely who have leukemia once they go into remission because the chance of finding leukemia is small and the risk and discomfort of the test is high. Whereas if we had a blood test when they come in once a month for follow-up testing, we may get an easy way to test early relapses that we don't have now and catch these children months before we would figure out what was going on.
So from an engineering perspective, doing these types of tests are not easy. There's a lot of work that goes into optimizing the design of these chips and using them appropriately for particular applications. And engineers don't know everything. Some of my colleagues may disagree with that. But getting involved with clinicians is extremely important because they can help us define the problem. What is the clinical need? And engineers really don't have a very good handle on that. That's why it's extremely important to get acquainted and hooked up and working with clinicians like Dr. August here. He defines the problem. He helps us make sure we're looking at and testing the correct patients and providing him with the necessary information to move this forward. And that's extremely important because we really need that. I mean, publishing papers on this type of technology and the results of our study are great, but we want this to be disseminated broadly to a large community, and actually helping define the clinical need is extremely important that the clinicians can help us do. Mm-hmm. And then the other thing too that I must say is that this whole area of lab on a chip, one of the biggest challenges with it is dissemination. That means getting it out into the marketplace so everyone can take advantage of this test, not just the patients at Children's Mercy Hospital, which are very important to us, but other people as well, other patients. And this is not something that we're doing alone. Keith and I are actually working with a company to actually help get this test disseminated into the community, broadly speaking, and that's a challenging endeavor in and of itself, because as you know, and a lot of the audience may know, it has to go through the Food and Drug Administration, and we're in the process of gearing up to do more clinical studies, more clinical tests. We're running one right now, but that was only 20 patients. We're gearing up to do many more patients through other funded studies to actually help pull this through the Food and Drug Administration to get it out into the community, so clinical decisions can be made based upon these type of tests.
Well, thank you, Dr. Soper and Dr. August. That's it for today. To learn more about KU Cancer Center's research efforts, visit the Research and Education section of kucancercenter.org. Join us next week at 10 a.m. for Bench to Bedside. Thanks for watching.